Warm greetings from Dr. Simran Parwani, Professor Periodontology, BYWS Dental College and Hospital, Amravati, Maharashtra, India. In 2023, I, along with my PG student, Dr. Dhanashree Chaudhary, did a mesotherapy with vitamin C by injecting vitamin C inside gingival tissues at epithelial connective tissue junction for gingival depigmentation in hyperpigmented gingival cases. And what we noted, apart from depigmentation, vitamin C has the capacity to increase the thickness of gingiva also, in turn contributing to gingival health in maintaining periodontal and gingival health. So coming to my presentation, today's topic is evaluation of gingival thickness with injectable vitamin C versus injectable platelet-rich fibrin after microneedling in thin gingival phenotype. So I'll be covering this topic under the following heads: basic concepts about gingival thickness, width of attached gingiva, color and texture of gingiva, microneedling, injectable PRF, its contribution of vitamin C in gingival thickness. Then coming to the case reports, actually we did a study on this, but we could not complete all the cases with 6 months follow-up. So how many ever cases we have completed? I'm presenting those case reports. So the objective, methods of measurement, the case reports, results, conclusion will be my headings. So coming to gingival thickness, it refers to the buccolingual dimension of gingiva, typically measured at free and or attached gingiva. It influences periodontal treatment outcomes, affects aesthetic results in implant and restorative procedures, and impacts gingival recession risk. So there are different methods of assessment of gingival thickness. First is transgingival probing, or known as bone sounding. It is performed under LA. Shows the cross-section of gingiva with a periodontal probe or an endodontic spreader. It is inserted perpendicular to the gingival surface until it touches the bone. And gingival thickness is the distance from the gingival surface to the bone. And it is used in clinical and cadaveric studies. Another method is by ultrasound measurement. An ultrasound transducer is placed on the gingiva. Sound waves penetrate the tissue. Echo return time is measured to calculate the thickness. This is also used in non-invasive studies. Next is cone beam computed tomography, also known as CBCT. A sagittal or axial slice from a CBCT scan is taken. Gingival and alveolar bone contours are seen, and the thickness is measured from outer surface of gingiva to bone on the software. It is a highly accurate method, but cost issues are there. It is used in digital dentistry and implant planning. Coming to the most widely used method, the visibility of the periodontal probe, or a direct measurement, also known as visual inspection method, shows a periodontal probe gently inserted into the sulcus. If the probe is showing on the surface, it is thin gingiva, otherwise it is thick gingiva. Not directly for gingival thickness, we are using this periodontal probe, but we can assess the sulcus depth, which can be related. And it's a very simple method, but less accurate. Then next method is needle insertion invasion technique. Needle is inserted perpendicular through the gingiva until bone is contacted. A rubber stopper placed to mark the insertion depth. Distance from the stopper to the tip is the gingival thickness. It is used in invasive studies, but it is an accurate method, often used in surgeries also or cadaveric studies. So average values have been proposed for thickness of gingiva by many authors. Bowers et al. Has mentioned in 1963 that 1 mm of thickness of gingiva is enough to maintain the health of the periodontium. Lang and Low in 1972 has mentioned 1 mm is enough. Goaslin et al. In 1977, according to him, 1.25 mm is enough. Siebert and Linde in 1989 and Olson and Linde in 1991 have mentioned that 1.5 mm of gingiva is thin and 2 mm is thick. So 2 mm is a better option for surgical procedures whenever you are attempting root coverage procedures or implant surgeries. At least 2 mm of gingiva should be there for proper maintenance of restorative or implant procedures. Then Egger et al. Has mentioned in 1996 that 1.5 mm of gingiva should be at least there. Barley et al. In 1999 have found that if the gingival thickness is less than 0.8 mm, it is known as thin phenotype and it really affects the gingival surgical procedures prognosis. So whenever you are taking any root coverage procedures or implant, if you are placing, there the gingival thickness should be at least 0.8 mm or more. So clinical relevance is if it is a thin phenotype, there is higher risk of recession, less predictable healing is there. If it is a thick phenotype, more stable tissues are there and they bring out better surgical outcomes. Then coming to the another most important terminology, width of attached gingiva, or you can say width of keratinized gingiva. Width of keratinized gingiva is width of attached gingiva plus that of marginal gingiva. It is the distance between the mucogingival junction and the projection on the external surface of the bottom of the gingival sulcus or the periodontal pocket. And in simple words, according to Orban in 1948, it is the gingiva which is firmly bound to alveolar bone. Its importance is main three important characteristics it has to maintain. It resists the plaque from invading in deeper tissues of the periodontium, hence to distant organs also, resists the masticatory forces while chewing, also resists the frictional forces from surrounding musculature while talking or any activity of the lips and surrounding musculature. So test for assessing the width of attached gingiva. Simplest method is the measurement approach. The pocket or the sulcus depth is measured and then the total width of the gingiva is measured. That is from the gingival margin to the mucogingival line. And then width of attached gingiva is B minus A. In this picture, you can see very nicely. First, this total width is measured, and then only the sulcus width is measured, and then this sulcus width is minused from the total width, and that is known as attached gingiva. This attached gingiva helps to resist all the masticatory forces, frictional forces, as well as resist the plaque from invading into the deeper tissues if it is of adequate width. Next, again, the same measurement method can be used with Schiller's iodine solution. Schiller's potassium iodine solution is used to paint the gingiva. And again, it will paint the alveolar mucosa more darker than the attached gingiva. And hence you can make out whether the attached gingiva is adequate or not by the same measurement method. This solution stains the glycogen content of the tissue, and the glycogen is more in alveolar mucosa than the attached gingiva. Because glycogen is utilized for the process of keratinization in the attached gingiva, this stain gives dark brown color to the alveolar mucosa and light brown color to the attached gingiva. Hence, you can make out which is the attached gingiva. Next test, which is the usually used test, and this is the easiest test, also known as tension test. This is done by stretching the lip or the cheek to demarcate the mucogingival junction and to see for any movement of the free gingival margin. If the free gingival margin during stretching of the lips is moving, then attached gingiva is considered to be inadequate. Coming to the roll test, easiest test, it is done by pushing the adjacent mucosa coronally with a dull instrument. If the gingiva moves with the instrument, then the width of attached gingiva is considered to be inadequate. If adequate width is there, then the gingiva does not move because the attached gingiva is firmly attached to the alveolar bone. So this is the roll test. Here we can see very nicely with the tine of the proof. If you move these tissues coronally, if they get moved, then the width of attached gingiva is inadequate. It has to be augmented by some augmentation techniques so that your forces can be properly borne by the periodontium, and it does not result in recession of periodontium. So average values for width of attached gingiva have been given numerically by many authors, mainly NMO and Lowe in 1966 have mentioned that minimum of 2 mm of keratinized gingiva should be there for proper maintenance of health of oral hygiene, of oral cavity, including 1 mm of attached gingiva and 1 mm of marginal gingiva. This is sufficient to maintain gingival health, whereas Linde and Nyman in 1984 have mentioned even with minimal attached gingiva that is less than 1 mm, gingival health can be maintained if plaque control is adequate. So then coming to the next characteristic taken in this study, color of the gingiva. Normal color of gingiva is coral pink in American population, whereas in Indian population we have pale pink color with melanin pigmentation. Factors responsible for this color are vascular supply of the tissues, thickness and degree of the keratinization of epithelium, and presence of pigment-containing cells. This color will change if there is inflammation of the gingival tissues, especially when plaque is not able to, if the patient is not able to maintain plaque and proper oral hygiene, then there will be inflammation of the tissues, and it will result in grayish red color because of venous taches, because of chronic gingivitis. So coming to the color changes, these are the generalized color changes seen in inflammatory gingivitis, and these are localized changes. These are acute changes which can be seen because of inadequate plaque maintenance or oral hygiene maintenance. So all these need a good thickness of gingiva or good width of attached gingiva so that color changes or inflammatory changes do not occur in the periodontium. So coming to the texture of gingiva, one more characteristic of this study. Normal texture of gingiva shows stippling. Stippling is an orange peel appearance or minute depressions on the surface of mucosa. This is the form of adaptive specialization or reinforcement to function present in all mucous membranes and the skin. It is for resisting the epithelium from getting worn off or so that the plaque microorganisms do not get entry into the deeper tissues. So here it's a feature of healthy gingiva, and reduction and loss of stippling is a common sign of gingival disease. Stippling is produced by alternate rounded protuberances and depressions in the gingival surface. Papillary connective tissue layer projects into the elevations of epithelium, and these elevated and depressed areas are covered with stratified squamous epithelium, giving it an orange peel appearance or minute depressions on the mucosal surface. Stippling is best viewed by drying the gingiva and observing in natural light. In acute inflammatory conditions, when gingiva is soft and edematous, stippling is lost. In fibrotic chronic inflammatory conditions, stippling is increased. So in this picture, we can very well appreciate this is all orange peel appearance, a hallmark for healthy gingival tissues. Here we can see loss of stippling because of inflammation, because of recession, because plaque is not being maintained by the patient, oral hygiene is not being maintained by the patient because of less thickness of gingiva or less width of attached gingiva. Coming to another important terminology, gingival phenotype. Biotype is determined by same specific genotype, whereas phenotype refers to the physical appearance of an organism, which includes multiple factors like environment and clinical interventions, which are site-specific, including the expression of biotype. Now, gingival phenotype is a three-dimensional entity, or it is also known as gingival volume. It is inclusive of gingival thickness, that is GT, gingival keratinized tissue width, that is KTW. Hence, I will use these short forms. When considered along with buccal plate thickness, it is referred to as periodontal phenotype. But because in our proceeding case reports, we have not taken into consideration buccal plate thickness, we have considered only GT and KTW, we are using the term gingival phenotype. Each person has a distinct gingival phenotype, which depends on the size, location, texture, and shape of the gingiva. Individuals with thin gingival phenotype cannot maintain their oral hygiene and frequently exhibit gingival recession as slightest trauma produces inflammation in their gingiva. Coming to the procedures which we have used in this study, first is microneedling, also known as percutaneous collagen induction therapy in derma. Here a 30 gauge or any needle is taken. A 30 gauge lancet needle was inserted by us in horizontal direction on the gingival surface until a hard tissue surface is reached. And this is done on keratinized gingiva and alveolar mucosa in lower anterior sexton for 4 sessions in our study. So by this, we create numerous pinpoint bleeding microchannels which are created in the region to be treated. And these micro injuries cause superficial bleeding areas and create a wound healing cascade, releasing growth factors like transforming platelet-derived fibroblast and connective tissue growth factors. These growth factors promote proliferation of new cells, and these are immediately released after the microinjuries. And these fibroblasts promote new angiogenesis, that is formation of new blood vessels, and new collagenoses, that is formation of new collagen fibers. All these contribute to increased gingival thickness. Next component in our study is injectable platelet-rich fibrin, also known as i-PRF. Preparation of i-PRF includes following. After taking consent from the patient to withdraw blood, venous blood sample is collected using 10 ml syringes, and these are separated into 2 i-PRF plastic vacutainers. And these are centrifuged at room temperature for 2 minutes at 2000 rotations per minute with a simple tabletop centrifuge machine. After the centrifugation, we get an upper layer of straw-colored fluid, which is known as i-PRF. It is prepared, and this is aspirated with a syringe and injected into the tissues in the treatment site under L. i-PRF is rich in growth factors, platelets, and leukocytes, so it promotes regeneration process at low speed centrifugation. So we are just using only 2000 RPM for 2 minutes. Again, now this is the main hero of our study, vitamin C. It is an antioxidant which promotes post-operative healing of all tissues. It has a contributory effect on reducing gingival hyperpigmentation, as I mentioned earlier, and it promotes collagen synthesis, differentiation, and maturation of fibroblasts, which are the main cells for collagen formation, increasing the gingival thickness. Role of microneedling alone and along with i-PRF have already proved in literature to increase GT. But whether vitamin C can contribute to gingival thickness is not yet evaluated by studies. Hence, the aim of the present study or the present case series of ours was to comparatively evaluate the effects of vitamin C and i-PRF after microneedling for gingival augmentation in thin gingival phenotype. So objectives of our study were to evaluate and compare the differences between GT, KTW, gingival color, and texture with injectable vitamin C and i-PRF after microneedling in thin gingival phenotype at baseline and 6 months after completion of treatment. So we evaluated the previous studies, as I mentioned, Ozagir et al., in 2020 have evaluated the effect of microneedling alone and microneedling with i-PRF on the other side in 4 sessions at 10-day intervals, and that 6-month study concluded that i-PRF and microneedling are better than microneedling alone for increasing GT. Next study by Chetna et al. In 2024 evaluated the same thing, and they also found good results with i-PRF and microneedling compared to microneedling alone. Now, Davar et al. In 2025, just like our study, they performed a study to evaluate the effect of microneedling combined with vitamin C mesotherapy just for gingival depigmentation. So their primary focus was on reducing melanin pigmentation, but the study also observed a potential increase in GT, suggesting that this combination may serve dual purposes in enhancing gingival aesthetics and health. So coming to our study, our methods of measurement for GT, we took a number 10K file, which was placed in the center of a 3 mm diameter silicone disc. Just I had shown the picture before. File was inserted perpendicular from the vestibular midpoint at 1.5 mm apical to the gingival zenith. Zenith is the highest point or the deepest point. For the lower incisors, it will be lowest point. For the maxillary incisor, it will be highest point. So through the gingival tissues until a hard surface is felt. So in this picture, you can very well appreciate this is the silicone disc and this is the gingival zenith. We have placed the margin of the silicone disc at the gingival zenith, and this is your file, which is 1.5 mm apical to the gingival zenith. And this is just introduced horizontally from the gingival surface until the hard tissue surface is felt. Silicone disc was laid in tight contact with the soft tissue surface as the marginal gingiva overlapped the coronal border of the disc at that time. Depth of penetration was measured between the disc and the file. Then again, KTW was measured with whether it is adequate or inadequate with tension test already described, and numerical distance from the pre-gingival margin to the mucogingival junction was also measured using a Williams graduated periodontal probe. It is a calibrated periodontal probe with markings from 1 to 10 mm, 4 and 6 are missing. So it is good for measuring the gingival tissues width. Soft tissue color, post-operative color was matched or compared to the baseline color. So obviously when we took cases, they had inflamed gingiva. They had inflamed gingiva, which were showing chronic gingivitis color like grayish or a bluish red color. And when we successfully treated them by increasing the gingival thickness, we found healthy gingiva. So score 0 was given when there was no difference between baseline and 6-month values. Score 1 with moderate difference. Score 2 was with obvious difference, means the gingiva became very much healthy and pinker in color as compared to inflamed gingiva, which was present previously. Same for soft tissue texture also. Pre-operative values and post-operative values were compared, and then score 2 was given to the best texture. Then gingivitis index was taken according to Lowen-Silnes 1963 index for checking the inflammation of the gingiva. Similarly, plaque index was recorded according to Silnes and Low 1964 index. Post-operative care, which was advised to the patients, was do not spit or gargle vigorously on the first day after the procedure. Place a cold compress superficially on the skin, overlying the treated site immediately, every hour, 5 minutes off and on every hour. Maintain oral hygiene with finger for the first day. From the second day onwards, soft tissue brush can be used with modified Charter's method, not touching the gingiva. Warm saline or chlorhexidine gargles to be done 2 to 3 times a day from the second day of the procedure, and mild analgesics were prescribed. Coming to the cases, this is my first case, that is vitamin C case. Here you can appreciate thin gingiva. Thickness of gingiva is thin. With a periodontal probe, we have marked the width of attached gingiva. It was inadequate, especially for 4-1. For 4-1, there was zero width of attached gingiva. Just make a note of this. I'll show you the changes in the post-operative period. And the thickness of the gingiva as a whole was very less. It was less than 0.8 mm as described by Baldi et al. In 1999. So we measured the GT also, and we transferred the measurements to the vernier caliper and then marked in the charts. We took a lancet, just a simple lancet from patho department, and we did the microneedling procedure. So this was a microneedling procedure. Just pinpoint punctures were made in the whole gingival surface on the alveolar mucosa and the attached gingiva, nicely 1 or 2 times to and fro, and then we covered the area with a periodontal pack for 10 days. Similarly, after 10 days, in the second appointment, we did microneedling again. Third appointment, again, we did microneedling. All these were done at 10 days interval. Then again, fourth appointment, covered with a periodontal pack. In the fifth appointment, we used vitamin C and we injected it at epithelial connective tissue junction in whole of the alveolar mucosa and attached gingiva, keeping the bevel of the needle upwards. Same way, sixth appointment, after 10 days, we use vitamin C injections. This is also known as vitamin C mesotherapy. And we did a little bit of frenotomy in the lower vestibule. This frenum was pulling on the gingiva here and causing more recession. After 6 months, we saw the gingival thickness and again the width of keratinized gingiva. Here you can appreciate in 4-1 region, zero width of attached gingiva has turned into 2 mm of width of attached gingiva, which is a great achievement. And then again, thickness of gingiva was increased, and this was the total vestibular depth also. Patient is able to maintain oral hygiene very nicely. Coming to the second case, i-PRF case. Here we can see it is a thin gingiva, took the measurements of GT, and then they did the microneedling procedure. Second appointment again after 10 days. Third appointment after 10 days. Similarly, fourth appointment. Fifth appointment, we used i-PRF. Straw-colored liquid was removed, aspirated with a syringe, and then injected at epithelial connective tissue junction at 2 to 3 mm apart, 0.1 to 0.2 ml injected. Similarly, sixth appointment, injected straw-colored fluid, and this is the final position on the sixth appointment. After 6 months, there was an increase in the width of keratinized gingiva, thickness also. So coming to the results, there were changes in the KTW from around, these are the teeth number, and this is the baseline measurement, and this is the 6-month measurement. So there were changes in the KTW from around 1 mm or to 3 mm, and especially in 4-1 area from 0 mm to 2 mm with vitamin C case. And thickness of gingiva was mainly increased from around approximately, 0.5 mm to 0.9 mm, 0.5 mm to 1.1 mm. So all these changes, and especially the width of attached gingiva was increased tremendously. 0 became 2 mm with vitamin C. Similarly, i-PRF case, these are the tooth number, and here these are the baseline measurements. These are the measurements after 6 months. So there were changes in KTW and also the thickness of gingiva, but the changes were little lesser as compared to vitamin C. So coming to the results, significant increase in GT and KTW was observed at 6-month post-operative time compared to baseline in both the groups. A significant change in the color of the gingiva from reddish grayish pink, that is inflamed gingiva, to pale pink or healthy was observed after 6 months of treatment in both the groups. A significant change in texture from stippling not present to present 6-month post-operative treatment was observed in both the groups, but the results of vitamin C group were more better. But still, we couldn't do statistical analysis because too many cases we could not complete. But this was a 6-month follow-up of these cases, and we will complete the study and get a statistical analysis done. So coming to the discussion, gingival phenotype poses significant clinical challenges, including a higher risk of gingival recession, poor wound healing, and susceptibility to mechanical trauma. Microneedling combined with i-PRF or vitamin C presents a novel, minimally invasive alternative that utilizes body's natural healing processes, that is growth factor release, to enhance collagen production and improve gingival tissue quality. Microneedling, a technique widely used in derma for skin rejuvenation, has shown promising results in stimulating fibroblast activity and collagen synthesis, as studied by Lee et al. In 2014. Although most studies on microneedling have been conducted on skin, preliminary research on oral mucosa and gingival tissues suggests a similar biologic response as mentioned earlier by Ozagir et al., Adhikari et al., Chetna et al., and Davar et al. In 2025. Vitamin C also acts, microneedling also acts as a cofactor for prolyl and lysyl hydroxylases enzymes, which are essential for collagen maturation and stability. According to Swarna et al., microneedling group showed improved wound healing and a more uniform depigmentation effect, indicating potential benefits of combining microneedling with vitamin C in gingival treatments. Chaudhary et al. With myself in 2023 and Davar et al. In 2025 have successfully used vitamin C mesotherapy in gingiva without any side effects or good healing properties. Coming to i-PRF, it is also has a lot of advantages in regeneration process. That is, it is rich in platelets, leukocytes, and growth factors. It also helps in higher fibroblast migration as well as higher expression of platelet-derived growth factor, transforming growth factor, and type 1 collagen synthesis. It also forms a 3-dimensional fibrin matrix, which plays a greater role in tissue repair. Fibrin also acts as a scaffolding biological material for agglomeration of adherent cells at the site of tissue healing. Also, fibrin is a carrier of growth factors in a well-controlled release system that sustains proper bioactivity over the healing period. So coming to the conclusion, microneedling combined with vitamin C or i-PRF represents an innovative, minimally invasive approach to increase GT in individuals with thin gingival phenotype. Gingival inflammatory processes can be reversed to help preventing plaque retention, gingival recession, and trauma in thin gingival phenotype individuals. These techniques offer a patient-friendly alternative to surgical interventions, improving both periodontal health and aesthetics. Thank you so much. Thank you so much for patient listening.
Ayurveda is an ancient Indian system of medicine, which means science of life. The concept of Ayurveda is based on balancing the 5 elements: space, air, fire, water, and earth, which is also called as the Pancha Mahabhuta, and the 3 doshas, Vata, Pitta, and Kapha. Ayurveda believes that each individual has unique constitution, which is called as Prakriti. So, treatment should be specific to each individual. Ayurvedic surgery, which is also known as Shalya Tantra, focuses on surgical procedures and techniques. Sushrut Samhita, the textbook of Ayurvedic surgery, thoroughly describes detailed numerous surgical procedures, instruments, and techniques. Acharya Sushruta is also known as father of surgery. Acharya Sushruta, 6th century BC, had major contribution in the field of surgery. Sushruta performed this surgery a millennium before Hippocrates. This is a picture of Acharya Sushruta, which is also known as father of plastic surgery. In ancient period, the common punishment given to the soldier was to cut away earlobe, nose, etc. Indian surgeons were very skilled to correct the deformity by reconstructing the nose and ear by grafting the skin flap from forehead and cheeks. The concept of skin graft mentioned by Sushruta is cutting out living tissues from cheek and forehead region and rejoining it over the injured area. Sushruta stated the importance of preserving the functions and structures of the human body. He described Sandhana Karma, which means reconstruction, to restore natural form and function of body. He described various Sandhan Karma such as Karna Sandhan, Nasa Sandhan, Oshta Sandhan. Principles of Sandhan Karma or reconstruction: preservation of vital structures, restorations of function, wound management. For wound management, Acharya Sushruta described 60 various techniques for wound management. And the fourth one is to achieve hemostasis. How the hemostasis was achieved during the ancient period? Hemostasis is described by Sushruta and it is achieved by 4 ways. The first is Sandhan, that is rejoining. Second, Skandan, that is clotting. Third, Pachan, application of medicine, herbal medicines, which includes in a powder form and in a liquid form also. And the fourth one is Dahan, that means cauterization. By these 4 means, the hemostasis was achieved. Karna Sandhan. Karna Sandhan was first mentioned in Sushrut Samhita, the textbook of Indian surgery. Karna Sandhan means the repair of external earlobe. Detail had been described by Sushruta for reconstruction of ear. He described 15 types of methods for ear reconstruction, by means of which the improvement in the deformed ear is achieved. This is how the Karna Sandhan was done, or the lobuloplasty was performed. Nasa Sandhan, that is mean rhinoplasty. Sushruta mentioned Nasa Sandhan, that is rhinoplasty, for reconstruction of nose damaged by disease or trauma. During the war, this happens many times. So, for rhinoplasty, a triangular skin flap from cheek is used to repair the nose. How the skin flap is, a triangular skin flap is removed and it is used for rhinoplasty. He also mentioned Oshta Sandhan or lipoplasty, that is reconstruction of lip due to trauma or congenital deformities like cleft lip. Apart from that, Acharya Sushruta or the Indian surgeon also perform many cataract operations. Sushruta is supposed to be a pioneer of cataract surgery, specifically the couching technique. He also described other surgical procedures and concepts in ophthalmology also. Evidences of plastic surgery in Sushrut Samhita. before a long time, in Sushrut Samhita, a textbook of surgery, ancient Indian surgery, there are many examples of plastic surgery was performed during ancient Indian period. The first one, the Indian Lord Ganesha, is the most unique example of organ transplant. Acharya Ganesha's head was transplanted by the head of elephant. Is it it was too advanced technology that the animal organ was transplanted to the human being, which is it has also limitation in modern surgery also. The Ashwini Kumars, the surgeon, ancient duo, was a famous ancient surgeon duo. They transplanted the leg of Queen Vispala by the iron leg. She was injured during the war, and her leg was transplanted by the iron leg. Just like we in a current situation, we do it by plating also. They also rejoined the head and trunk of Acharya Chavanya Rushi Chavan, which was injured by Daksha. They also operated the excised head of Yajna. This suggests that they have also performed the craniotomy. Burn skin was cured by skin grafting. Corneoplasty of blind convo was done. This example shows that the surgery in ancient India was too advanced that they also transplant the organ of animal in human being. The surgical instrument was used by Sushruta for a surgery was, I am showing some pictures how the surgical instruments was. These are some instruments. Acharya Sushruta described 101 and blunt instruments and 20 sharp instruments. The blunt instruments are known as Niyantras and 20 sharp instruments known as Shastras. These are the pictures that instruments was used during the surgery. Further that, he described 4 types of suturing, which is known as Sivana Karma. First is Vellitak, which is similar to continuous sutures. Second, Gofanika, similar to blanket sutures. Tunna Seveni, just like subcuticular suture. And Ruju Granthi, it is similar to interrupted sutures. Many of surgical procedures described by Sushruta are remarkably similar to modern techniques, showing the excellence of his surgical knowledge. Sushruta's approach to reconstructive surgery highlights the advanced state of surgical procedure in ancient India. Use of herbal anesthetics and post-operative care described by Sushruta made the foundation of surgical practices. This was my short presentation to show how the ancient surgery in India was on the top. Thank you everyone for listening me, and thank you organizers for giving me the opportunity to share my views in front of you. Thank you everyone.
Thank you so much, Dr. Shilpa. That was
a novel molecule we developed at BII Biosciences is reshaping how we approach skin regeneration in clinical and real-world settings. We will look at mechanistic data, clinical evidence, and treatment outcomes. Cool. Let me go to the next slide. So is everybody seeing the slides fine? Okay, yes. So when we designed the diamondcore zinc oxide, we wanted to create a multifunctional molecule that could regenerate skin structure, calm oxidative stress, and help correct pigment and barrier dysfunction. We call it the first principle solution for skin aging. And this is a core shell architecture of the diamond core zinc oxide. It features a nano diamond core enclosed in porous zinc oxide crystalloids. This unique design enhances the surface area so as to improve stability, and most importantly, it introduces reactive oxygen species scavenging and regenerative behavior far beyond the traditional UV filters, which zinc oxide is known for. So in a in vivo scratch assay, what we see, it's an in vitro scratch assay. We see here, the fluorescence cell are the skin fibroblast cell, and we have a anti-ZNO, which is the nanodiamond zinc oxide treated fibroblast. It closed the wounds twice as fast as the control. So this is 0 hour, and this is after 24 hours. So we see for the control, the cell migrates to like about half. But then for the diamond core treated wound, we actually have migrated everywhere. It's twice as fast wound closing with the diamond core treated fibroblast. And then in a in vitro aging model, we have UVA aged fibroblast. It typically loses their ability to produce collagen after UVA treatment. However, was treated by diamond core zinc oxide, these cells recovered over 70% of their collagen output. And in some cases, they outperform the baseline levels, which means it's even better than before UVA treated, indicating that we don't just prevent, we actually repair the existing aging effect on the fibroblast. One of the key mechanisms behind this regeneration is the oxidative stress reduction. In a side-by-side assay, the diamond core zinc oxide reduces the ROS by about 80% as compared to untreated controls. And this level of ROS control is actually central to preventing dermal damage, pigment instability, and inflammation in the skin, which is the root of all like aging. And we also found that our nanodiamond zinc oxide has 5 times better absorption in the UVA region than the conventional zinc oxide available on the market. As we can see for the UVB and the UVA, and this is the conventional zinc oxide on the indicated by the pink one. So this enhanced the UVA protection allows us a superior defense against photoaging, pigment disorder, and dermal thinning. So what is important is that this protection is delivered without relying on chemical additives that can irritate sensitive skin types. And we are using pure like mineral, which is zinc oxide, as the photoaging protection, which is perfectly safe for everybody. And to summarize our molecule is that our nano diamond zinc oxide eradicates 80% of the reactive oxygen species, while other antioxidants like vitamin C only can do about 48%. We also induce 198% of fibroblast regeneration with as much as twice in a in vitro wound healing assay. And our control is about which is an exosome containing product which enclosed the wound by about 148. We heard an excellent talk about exosome, how it enclosed wound just now. And we're just saying that our nanodiamond zinc oxide has the similar effect in wound healing aging. And again, we have 5 times better photo protection in the UVA, UVB region, as well as the high energy visible light region than other conventional UV filters that are available on the market. So we have actually launched a product called Dynamic Age Defense, which is a breakthrough biotechnology that regenerates skin at cellular level. It's proven to reverse major signs of skin aging, regenerate like useful skin. We accelerate wound healing and prevent environmental and UV damage. So there are two use cases of our product. And the first use case is that we can use it as a daily regenerative skincare, which it is good for long-term to treat long-term inflammatory skin conditions as a photoaging prevention and treat melasma, rosacea, acne, etc. We can also use it as a post-cosmetic procedure healing aid. So we have done clinical studies with both ablative and non-ablative procedure, including what we know like carbon dioxide laser, RBM YAG laser, IPL, PDL, radio frequency microneedling. We've done clinical studies with these treatments, and we've seen noticeable improvement with the aid of diamondcore zinc oxide. So we support better procedure outcome, and so that our molecule becomes part of the protocol itself. It improves healing and minimizes the side effects like PIH or prolonged redness. So I'm about to show you some of the studies we've done in clinical. So here we have a patient with skin presented with melasma and diffuse hyperpigmentation, particularly on her cheeks, jawline, and the upper lip, which we know as melasma mustache on the left, which is week 0 before. So she began applying an nanodiamond zinc oxide containing cream once daily. And at week 8, we do a digital analysis and we confirm a significant improvement on the hyperpigmentation, as well as improved overall uniformity in her face. Another example of age-related skin laxity. So this patient on the left here, she has age-related hyperpigmentation, uneven skin tone, early signs of photoaging, and after consulting an expert, so she started using our nanodiamond zinc oxide containing skin preparation for once daily. And after 8 weeks, we observed the skin appear more youthful and bright. And then we also noticed like a diminishing of fine line, overall skin health looked enhanced, and also have done with the inflammation, it has been reduced. So another example here is a patient here with rosacea with significantly facial redness at baseline, especially across like cheeks, nose, and chin. So after 8 weeks of using our nanodiamond zinc oxide containing sunscreen, which is a skin preparation we launched once daily, after 8 weeks, we can definitely see improvement with the reduction of the redness. Another example is this patient on the left here with mild, like very mild this pigmentation here. So she had a history of occasional sun exposure without consistent sunscreen use. And she had noticed an increase in small, scattered dark spots on her cheeks over the past years. So this pigmentation is not here. And like usually patients want to do with a more conservative treatment instead of doing like a laser or something. So she seek for a topical solution, and then we offered her this nanodiamond zinc oxide treatment. She applied it once daily for 8 weeks, and on the right we can see like even for this very mild dyspigmentation, we can see improvements on the dyspigmentation on both of her cheeks over as short as week 8. So if you ask me, I would say like for this pigmentation usually take place maybe after week 8 and maybe even after week 12. So I would say if she continue using like this nano diamond core zinc oxide, she will see even further improvement down the road. And even this is like very mild this pigmentation to start with. So here we are seeing as I said, the post-procedure treatment with our nanodiamond zinc oxide. We have a patient with acne, concerned by acne scars and uneven skin texture. She underwent a erbium YAG laser procedure, and we took a picture immediately post-procedure. It is very red because it's ablative laser treatment. And we applied our zinc oxide, nanodiamond zinc oxide containing skin preparation immediately after the procedure. And we took pictures at 3-hour, 1-day, 4-day, and 6-day marks. The treated area has like very severe redness at first, but after 3 hours, we already see improvement on the redness. And by day 1, we have visible improvements in the skin texture and the reduction in redness. And the wound healing is definitely accelerated compared to typical recovery timeline for this kind of ablative laser procedure. And by day 4, we have seen the treated area recovery with reduction in inflammation. And the complete recovery we observed at day 6. So typically it takes a patient about 10 to 14 days to recover from such ablative erbium YAG laser procedure. But here with the aid of nanodiamond core zinc oxide, we achieve a recovery in 6 days. And the patient doesn't self-report it, doesn't feel any steaming, and it's very mild for her skin to tolerate. So another case we have here is a patient underwent a hybrid laser treatment combining ablative and non-ablative wavelengths. So post-treatment, we applied nanodiamond zinc oxide containing cream daily in the morning to the treated areas. Day 7 and day 30, we have documented her recovery. So this is a very ablative laser, and by day 7, the patient exhibited significant redness as expected. This is because like the skin barrier is disrupted. But by day 30, we see there's a complete resolution of post-procedure redness, and the patient's skin showed notable improvement in tone and texture with a reduction in fine lines and photo damage. Also, like during the entire course of the post-procedure healing, the patient didn't feel any uncomfortableness of using our nanodiamond zinc oxide containing skin preparation. So another case of using a combination of ablative and non-ablative laser healing we see here is that this patient, it's the same procedure as the last patient. After 1 month post-procedure, we see a very well recovered skin with mild redness. And after 2 months, she has completely recovered to a better and brighter skin tone. So we would say that as compared to typical halo, like a ablative laser recovery, with or without zinc oxide, nanodiamond zinc oxide, the recovery timeline is very different. By applying nanodiamond zinc oxide daily, definitely shortened the recovery time as well as improved the outcome. So we see here is another patient. She used a combination of rejuvenation procedure, including a radio frequency microneedling and erbium laser treatment. So following both treatment, the patient applied our zinc oxide, nano diamond zinc oxide daily in the morning to the treated area. And we took photos on a 3-hour post-procedure, 1 day, 4 day, and 10 days. I think what amazed me the most is that after 3 hours following the treatment, the patient's skin, although exhibit redness, and bleeding and mouth swelling, which is typical for the procedure, but with application of our nanodiamond zinc oxide, we do see an immediate relief of the redness on the patient's skin. And also, like after 1 day, 4 days, we see like a recovery that is much faster than a typical post-procedure recovery. And by 10 days, we will say that the skin has achieved complete recovery. Remember, this patient has done both the microneedling and a RBM laser, so it's ablative, and she was managed to recover, total recovery in 10 days. So we are thinking that maybe including our nanodiamond zinc oxide containing skin preparation in the post-procedure recovery protocol would reduce the downtime of ablative treatment and also improve the outcome. Another example we have here is, again, the microneedling. We see immediately post-operation, similarly, we do have redness and inflammation, but just after 1 day or 2 days, we see like drastic improvements on the inflammation, the redness, and 3-day post-operation of the microneedling, we see a complete recovery, which again is compared to a typical recovery timeline is much faster. So as to summarize, so our diamondcore zinc oxide is a regenerative molecule with potent effect on dermal repair. It has improvements on oxidative stress control as well as pigment stabilization. It works across conditions, ages, and skin types. So thank you so much for your time. I can be reached at this email, diana@biosciences. If you have any question or if you wanted to learn more about our product or even trying our product. So yeah, thank you so much for having me here.
Thank you so much, Dr. Zingi Diana. It was an excellent presentation. Moving on to the next presentation, I would like to invite...
I have a question?
And functional changes, especially in our eyelids area. So in this context, blepharoplasty, a surgical procedure, aims to correct those changes. Here in Brazil, our unified health system guaranteed to our citizens the right to undergo this surgery because of this importance. So the aim of this search, this scope and review, is to understand the relationship between the impact of quality of life and blepharoplasty and the reinsertion of the surgery in our Brazilian public health. About our methods, just a minute, please. Okay, thanks. About our methods, we selected studies. Just a minute, please. We selected some studies from 2017 to 2022 in English, Portuguese, and Spanish, using the descriptors quality of life, blepharoplasty, visual field test, patient satisfaction, and health unique system. In the end of the search, we selected 13 studies about that topic. About our results, only 7 of these studies talked about the improvement in quality of life. 5 of them found a significant increase Only one find it a no difference, and another one found a low impact, right? Another 6 studies analyzed it. The Are you hearing me?
Yes,
Hello?
doctor. Yes, doctor, we can hear you.
Okay, I'm sorry. The another 6 studies analyzed the functional results of upper blepharoplasty, a criterion that we consider by the present review as a possible factor that should improve in quality of life. Of these studies, 3 found a significant increase, and another one, together with these another studies, demonstrated excellent levels of correction or in the metal calluses. And in the end, another 6 studies evaluated the subjective issues that may be linked to improve quality of life, such as patient satisfaction, headache improvement, psychological well-being, and self-esteem. About the insertion of the surgery in our public system health, we didn't found a lot of searches about it, and we didn't found no data about SUS waiting list, as well as the number of blepharoplasty performed per year. So we didn't have a real result about the insertion. So about our conclusions, we can say that we have a straight relationship between quality of life and blepharoplasty. There is a lot of benefits that comes from the surgery, like high satisfaction, improvement, self-esteem, increased field of vision, safety, and well-being. And how I said, we didn't find the real inclusion of blepharoplasty in SUS. No data was found about it, so demonstrating a gap in scientific knowledge aimed to this purpose.
Thank you so much, Dr. Lucas. That was an excellent poster presentation.
Thanks. Any question about the surge?